Usually, ito yung mga common causes that you will see among those babies or neonates, newborns that has deviations from the normals. Okay? Ayan. So, tingnan natin ito. Neonatal hypoglycemia. So anything, di ba? Kahit naman din sa matatanda, anything that cause a patient or especially babies, newborns, na decreased activity, tapos pangit sensorium, if they can become restless or as in yung feeling natin, even if just a hint that the baby is not okay, either it's just sugar or temperature. Una muna sige. Temperature first kasi important talaga to keep them thermally regulated, but at the same time, do not forget to get your sugar. Okay? So when we say neonates, ang term is a normal, less than 60 milligram per deciliter. And for the preterm, it's usually lower, so 45 milligram per deciliter. And then, again, disclaimer, okay, doon sa mga normal values natin, it depends on what you are trying to look at na references. Okay? So, when we say neonatal hypoglycemia, bakit nga ba nagkakaroon ng neonatal hypoglycemia? Okay. Pinakauna, meron tayong mga babies na born into gestational diabetes mothers. Di ba? Yung mga GDM natin na sinasabi. Now, Dok, bakit pag may GDM si mommy, hypoglycemic si baby? Okay, di ba dapat madami din siyang sugars? No, it's because when the mother, di ba, bago siya manganak, when the mother nag-go into labor, may mga maternal stresses din siya. So if the mom has increased sugars, sorry, hindi ko masulat. Paano ko ba to dito maka-try ng draw? But anyway, sige, I'll figure it out later this afternoon. So mataas ang sugar ni mommy during or before, right before giving birth. Or pag hindi na-control yung sugar ni mommy, mataas yung sugar niya, but unto the baby, it will pass through also. So, in utero, mataas po ang sugar ni baby at the same time, yung mga B cells ng islet ng pancreas ni baby ay nagiging hyperactive. So, ibig sabihin, nagwo-work din po si baby into decreasing that sugar in utero. So, ang nangyayari, nag-hyperplasia po. Kumaga, lumalaki din po yung kanyang pancreas. Okay? So, that keeps shooting up your insulin. And what does your insulin do? Diba? It will let you go down the sugar. So, plus that and the labor stress, maternal factors, lalo na kung, di ba, fundal push, hindi na po tayo nag-fundal pushing ngayon na, lalo na po pag fundal push, another stress to the baby that and so, mas mataas po yung mga insulin shoot-ups ng baby. So, all of that stresses, paglabas ni baby, hypoglycemic. Okay? Kasi paglabas ni baby in distress or kaya mataba, sasabihin, Dok, mataba naman yung baby kasi GDM si mommy. Hindi po. Kasi po yung nangyayari in utero, the baby already worked up their insulin to go down to that level. Again, in general po pala, sabihin ko na lang, pag sa babies po, pag mga patients natin ay pedya, anything na masobra or tumataas, kailangan pong ibaba. Lahat naman po ng kulang at mababa, kailangan pong pataasin or dagdagan lang. But we have to reach the euglycemic or kaya yung hemostasis. Yun lang po yung goal, okay? Anything in diseases, anything in any mga sakit, any in systems na i-go through natin today, yun po yung general rule na anything sobra, papababain para maging normal. Anything kulang, papataasin para lang din po maging normal. Okay? Ganun po iyon. So, again, pag neonatal hypogly, paglabas nga nila, nagkaroon na ng mechanism na nagtaas ng insulin and then bababa. Now, the baby becomes irritable, may mga restless, decreased activity, pangit yung sensorium, and now you cannot check the sugar. Nursing interventions for those babies na newborn who are not good activities or the upgrade is low, let's just say, Aside from thermoregulation, you have to get the sugar. So now these are the levels that you have to keep in mind for you to know if you have to report or call the attention of your pediatricians or the attending that, ma'am, this patient is hypoglycemic. Okay, so what else? Ano pang ibang causes? Pwedeng mga poor feeds. Okay, hindi na nga talaga masyadong magsasak even pag newborn. So ganun po, we have to check the sugar. How do you check your sugars? HGT or sa amin CBG, we call it. It's just the same thing po. Okay, paano kumukuha? We use the heel, di ba? Heel po ulit.
Yes.
Heel prick. Okay. Heel prick, always the outer because it has more vessels, tsaka mas madali siya mag-bleed. Okay, when you get the cotton, wet cotton, di ba? Oh, again, sorry. You have to explain everything to the mother. Pag okay naman yung story ng mother, pero pag hindi, okay lang. Pero if anything na in instance, you can explain what you're going to do, please explain the procedure, pakilala din po kayo, and then tell the mother the result and then interpret a bit, okay? So, wet cotton, heel prick, lateral outer. Pagka heel prick po, yun na po ba agad ang kukunin?
No.
Na sample ng blood
No.
that you will put into the glucometer?
No.
Okay.
No.
No. Okay, very good. Hindi po iyon. Kasi hindi pa yon yung accurate because of the alcohol that you have put. So, kaya po tayo may dry cotton, you have to wipe it first. As in, mabilis lang or damp lang, ha? Hindi po yung masyadong ano na. Kahit konti lang, just a little bit. So, prick, bleed it a bit, and then wipe it off first. And then you get now the second blood na pwede natin sa makikuha nyo. And then put it on the glucometer, the strip, and then i-read na natin. Mas accurate po iyon. Okay? So now, if you have your interpretation, pwede sabihin lang sa parents or normal, okay naman po, ganito, ganyan. And then, what do we have to do? Pag hindi naman natin Doc, normal, pero parang poor activity pa rin. Now, we have to investigate further ano yung problem. So, na-thermoregulate na ba natin ulit na maayos? Recheck ulit ng temperature. So, those are your nursing interventions. Now, how to go about with your neonatal hypoglycemia? Okay? Check your HGT, CBG, administer dextrose, sugars, and then inform your clinical attending. Okay. When you are trying to administer dextrose, sugars, of course, meron lang talagang specific na pwede pag sa gano'n ka preterm or ka term or kaya ka post-term. So be very careful. So when you're checking CBGs, di ba, hindi lang siya one after. So halimbawa, if you have noted the baby is hypoglycemic, check every 15 minutes first for the first hour, and then every 30 minutes for the next 4 hours, then every 4 hours for the rest of the first 24 hours of life. So ito po yung checking na sinasabi natin para po mas ma-monitor natin ng closely. May iba po kasi talagang baby na even after giving sugars, nag-correct ka ng first, meron pa rin talaga nag-hypoglyce. So nag-hypoglycemic episode pa rin sila in the succeeding hours. For the reason being that maybe they are not also they are not thermoregulated again, or they are poor suck, poor activity, and poor feeding. So you have to teach them again. Balik po ulit tayo doon sa lectures natin on how to properly latch the baby, how to properly feed the baby with the mother. Okay? So dapat talagang i-offer natin first and foremost the feeding, tapos kung able, but if not, we can give your IV dextrose and sugars. Okay? Sige. Next common na makikita natin always, di ba? The jaundice. Mommy or kaya si mommy na first time mom, especially when you go to your well baby clinic, di ba, mag-a-assist tayo. Minsan tayo lang yung nandun, nurses, tapos sasabihin sa atin na 19-year-old mother came in primigravid, di ba? So first baby niya, tapos sabihin niya, ma'am, sorry po, ma'am nurse, kasi my baby is just 3 days old, tapos po madilaw. My baby is yellow. How will I go about it? So, di ba, tatanungin din natin ulit kung, or isipin muna natin what kind of jaundice this baby has. Kasi may mga jaundice po din na iba-iba yung cause. So, we have to at least know the basic kung normal po ba ito or not. Okay? When we say jaundice or there is an increase in hyperbilirubinemia, the bilirubins are going up. So pag term patients po, more than 12 milligram per deciliter. And then, yung sinasabi natin na pwedeng sobrang taas na with the neurologic findings, it's that's your 20 milligram more above. Tapos may mga neurologic findings na, as I've said, kernicterus po iyon. But, bago pa po tayo pumunta ng kernicterus, that's the irreversible phase na kasi. So we have to be watchful, mindful pa lang sa mga yellow babies, mga jaundice babies na hindi siya physiologic. So we have to be very careful kasi po pag nag-kernicterus, irreversible na po siya. So we can do nothing about it. The baby will have neurological delays. So pwede po sila maging bobo at hindi na po natin talaga magagawan. So that's sad. So how to go about it? Okay, signs and symptoms. Aside sa discoloration, pinakauna saan nyo makikita yung discoloration ng babies? Most common.
Eyes.
Sclera, very good. Sa sclera, 'di ba? Makikita nyo na pag tumitibi, oh, mami, parang hindi po puti yung eyes. Okay, where else? Face, chest, trunk, abdomen, tas going down. Okay. Ito po yung ginagawa ko pag nag-eyeballing ako sa mga babies natin or kaya sa clinic na yellow. So, if you can just draw in your notes, a baby na may as in very vague na tao lang, tapos you have a cut off, lagyan nyo ng line yung head to neck, neck to waist, tapos waist going down the lower extremities. So if it's just here in your face, that's 5 milligram per deciliter. Neck to your abdomen, that's 10 milligram per deciliter. And then if it's going down to the level of your extremities, that's 20. Generalized na siya, okay? That's when you know na sobrang jaundice na ni baby or likely there is increase in your bilirubins kasi generalized na po. Pag nag-start po siya, it's cephalocodal. Pag nawala po siya, papaakyat naman. So the last thing or the first thing that you will see your jaundice is about in the face. Last thing na po napawala na rin is yung face. Okay, wag po makakalimot. Pero saan po mas accurate when we are checking the jaundice of the baby? Okay.
Clara.
When do we assess or how do we assess best if talagang may jaundice? Kasi di ba for those babies who are hyperpigmented yung skin, it can be very tricky. Mahirap siya, di ba? Kasi lalo na pag medyo ano sila, paano pag sinabi sa exam na Black American? Charot. Hindi naman po yan.
Soul ang thing.
Okay. Okay, may mga nag-message. Yes po, I will be sending and sharing again my lecture for today, but I will advise you to stay up until matapos po tayo kasi more of I will be discussing it talaga. Okay, so going back, pag nag-check po tayo ng babies, tapos halimbawa hindi natin sure if jaundice or not, broad daylight, okay? Mas maganda po yung natural sunlight lang, light lang po. And then, check for the abdomen. When you check for the abdomen, you slightly pinch it, parang deep pressure lang sa chan, diba? Soft pressure lang po sa abdomen and then you release. Makikita niyo po yung color talaga ng skin ni baby. So, press gently and then release. Check niyo po. And then how you know kung talagang jaundice or not, you can just like compare din po dito sa formula. Kaya sa other parts ng body, makikita nyo rin naman pag press yung abdomen. Okay? Minsan sa face ginagawa din, pero hindi. May nag-answer ng soft palate. Yes. Soft palate po is yun yung pinaka talaga accurate na nakikita natin. But this, hindi siya talaga napapansin. Especially pag nag-check up tayo or nag-evaluate. Tama po yung soft palate. Yan po yung pinaka dapat na check natin for the jaundice. But For checking, clinical or well-baby visit again, it is mas madali o kaya yun yung mas common. Proper way of checking for your jaundice is a natural sunlight, the abdomen part, you have to press it lightly and then release and check for the skin. Okay. So ano po yung mga signs and symptoms? Yellowish discoloration. So yun sinatawag natin icteric sclera. Face, skins, poor feeding, lethargic, and seizure. So yan na po yung mga later on part, mataas masyado bilirubin and then kernicterus. So how do we go about this? Ay, sorry. Ito pala. Sinabi pala dito yung how do we compare for both, for all. Okay. Hindi naka-mute si ma'am. Okay, we have to mute them all. Okay. And now, so di ba sabi ko sa inyo kanina, ano natin masasabi kung physiologic or pathologic? Again, pagtatandaan po natin yung mga ganitong table, mag-memorize na lang po ng isang side lang. Para po yung kabila, kung ano yung wala doon sa memorize mo, malamang at sa malamang nasa kabila. Okay po? Okay, physiologic. Usually it appears after 24 hours of life. So, ma'am, unang tatanungin, di ba, pag nag-jaundice, pumunta sa inyo, ma'am, sorry po yung baby ko, yellow po siya. Mami, kailan po, ilang araw na po siya, alang gano'n na po katanda si baby, at kalo po siya, kailan mo napansin yung paninilaw niya? Pag sinabing mga second day of life, may idea ka na it's physiologic. Okay, and then when you do or get your bilirubins, usually, pag nagmo-monitor tayo, less than 5 milligrams lang po ang tinataas niya in a day. Okay, and then nawawala po yung jaundice less than 14 days. So dapat on mga second week of life, pawala na po yung jaundice niya. Okay, bakit po? Baka may mga causes niya because of the immature liver. Okay, immature liver lang po. Especially for the preterms, mas likely po silang nag-physiologic jaundice. So intervention for this is we have to keep them hydrated and feed frequently. Sunlight exposure, yes. Pero halimbawa sa mga critical patients natin na naiwan sa NICU, okay, meron silang sinasabi na light. So, yun yung phototherapy. Pwede rin po sa mga physiologic yun. But usually what we advise is just frequent feeding. Okay. For the pathologic, again, kung ano yung wala sa kabila, opposite ng kabila. So, yung pathologic, sorry, hindi dapat yan beyond. Dapat siya ay within 24 hours ng kapag kapahanak. So within 24 hours and then you notice that the baby is jaundice, mag-isip ka na something is wrong. And then during na magtitake ka na ng bilirubins, more than 5 milligram per deciliter ang tinataas po in a day. And then your direct bilirubins is more than 2 milligrams. And then just nice to know lang tong may term and preterm. So I think just must focus kayo doon sa 5 milligram and 2 milligram ng direct bilirubins. Kasi more likely those are just indication that this is pathologic jaundice. And then for the pathologic jaundice, hindi po sila nawawala agad ng more than 14 days. As in matagal pa po sila. Okay. So what are the possible causes? Most common is your RH and ABO incompatibility. Okay, I will go through that later pag pumunta po tayo sa HIMA. I think HIMA, I'll discuss that one. Okay, so how do we go about the pathologic jaundice? It's phototherapy. Yun po yung nakikita natin na blue light. Hindi po yung yellow or parang or yellow light. Hindi po yun. Wala na rin po yun ha. Debunk na po yun na ginagamit natin. Nagsa-spotlight tayo kay baby for them to keep thermoregulated, di ba? Parang yung iba, ganun ginagawa para daw medyo warm. Wala na po iyon kasi it can cause burns. Okay, so what we do is the phototherapy, yung mga sinasabi nating firefly. So meron po siyang blue light. So pag intensive po, meron sa taas, meron din po sa ilalim. Pag pinatong mo si baby, nandyan lang siya. Okay? So nagpo-photo isomerization po iyon. But we have to cover the eyes. And then everything else ay nakahubad si baby. It's just covering the eyes and the genitalia. And then you place the baby in the phototherapy. Okay. And then of course, you have to take a break. Kasi i-feed mo sila every 2 hours. But then, after feeding, you have to advise the mother, advice po, na kailangan ibalik si baby. Ibabalik na po natin siya sa Billy Light or sa phototherapy. Okay. Billy Light at Billy Blanket po. I haven't used Billy Blanket, Ma'am Ann. Sorry po. I haven't used Billy Blanket. But Billy Light, we use Fireflies, both for the blue light up and down, and then yung intensive double phototherapy. That's what we have yet. Okay. Kernicterus, we just discussed this briefly para lang din may idea kayo. Kasi baka ang itanong po dito, reversible complication of your pathologic jaundice. Okay, so ano po ang nangyayari? Usually these patients or these babies, pag sobrang jaundice po kasi, yun, other symptoms ha, pag may mga jaundice babies, of course, for your baby visit, you have to ask them the other symptoms. Is the baby still feeding? Is the baby still active? Is the baby's good pa rin yung UO and then the bowel movement? Okay, if nothing is wrong with the baby, no constituent symptoms, walang fever, hindi nagtatae, nagsi-seizure ba siya? Okay, so anything na wala naman doon, likely the baby is just physiologic jaundice. But the moment that you've seen the baby that is very, very jaundice, tapos yung pagiging jaundice na po niya is parang golden. Okay, they're jaundice na parang yellowish. Parang pale yellow. But then when you see these babies na talagang golden yellow na, mahirap na yon. Kasi pag generalized, the more you have to be very alert that it could be kernic. Talagang umakyat na sa basal ganglia. So what happens? They can also seizure, lethargic. Yun na yung mga babies natin na hindi na natin magagawan masyado ng paraan. But what happens is with severe jaundice, more than 20 mg per deciliter, or yung iba nga pumapalo pa ng 28, 25. So what we do here is nagpo-phototherapy tayo, intensive, and then nag-IVIG. So the immunoglobulins will be given and you do your double volume exchange transfusion. Okay, talagang magla-line po tayo. Ginagawa po natin yun in your umbilical veins. Doon po tayo nag-exchange transfusion. Okay, so may iba po na pull out naman, but at the same time, we are trying to avoid this one. Sa lahat po ng jaundice, ito po yung dapat natin i-prevent. Yung sequelae ng pathologic jaundice. Okay. Next. Hindi, mami, irreversible na po siya. Meaning po na napupull out, at least the baby doesn't have any neurologic symptoms. Hindi na po siya nagsi-seizure, hindi na po siya nagkakaroon ng any ano. But the growth and development, you have to be very careful into monitoring this patient. Sa neurologic po, wala na po. Metabolic disorders, okay. Di ba na-mention natin before that the newborn screening, okay, ano nga ulit yung 6 na, ay sorry, ano ba yan? Yung 6 na sakit na nasa-screen natin when it comes to your newborn screening. Six diseases. 1, PKU, sabi ni Ma'am Rose Ann. Galactosemia.
G6PD.
G6PD. 3 pa lang. Ano pa po? Congenital hypothyroidism. 1 more. Ma'am, hindi po kasama ang cystic 5, pero sa state kasama po. You have to take for the extended newborn. Okay, the CAH. The CAH is your congenital adrenal hyperplasia. Okay, hyper ha, hindi po hypo. Okay, thank you. Sige, let's just try to discuss them. Okay, briefly, ano po nangyayari sa PKU, sa phenylketonuria? So, the high levels of phenylalanine, more than 20 mg per deciliter, ito po yung responsible ng pag-uptake ng mga neutral amino acid natin. So, pag wala po si phenylalanine hydroxylase, yun po yung nagkakaroon tayo ng no more No more uptaking. Okay? So, ang deficient po natin dito, tatandaan lang natin is your phenylalanine hydroxylase. Okay? So, maraming patients, di ba? Yung patients natin ng PKU, wala po silang symptoms at birth. So, the patients are asymptomatic up until a few days to few weeks. The patient now has neurologic symptoms such as your seizures. Likely po nagvo-vomit sila. Yung mga deep tendon reflexes po ay hyperactive. Okay? And then now you can, napapansin niyo yung mga mousy odor. Okay? Mapapansin niyo yun sa urine, pero usually meron din sa sweat. Okay? So may mga patients din tayo. So what happens kasi with this is, pag phenylalanine hydroxylase yung walang mga conversions of your amino acids. So, hindi talaga siya nagiging converted. So, pag na yun naman ang naging decreased, wala po tayong other proteins. Okay? So, yun po yung deficient niya. So, you just have to take note itong increased phenylalanine levels and then deficient in phenylalanine hydroxylase. Kasi po baka hindi i-mention na PKU siya, but at least you know na ano yung deficient, then likely that is the disease. Okay. Now, paano po sila madadiagnose? Molecular testing po ito ulit. Again, kasi this is an metabolic disorder. So more of talagang genetic-wise, talagang yun lang. Blood disorders, PCRs, lahat ng molecular testing, yun po yung gagawin. So just to be specific and for you to be familiarized, that's a Guthrie and Phenestick's test. Okay. Intervention, nursing intervention, what do we have to go about? Dietary protein restrictions po. So, di ba po mataas na ang phenylalanine na component dito sa sa mga PKU patients natin. So, bago pa po tuluyan, mas tumaas, di ba? Pag ano yung mataas, dapat ibaba natin to normalize. So, wala po tayong ibibigay ng mga proteins sa mga patients natin. I-restrict po natin yun. Kaya po may sinasabi tayong sick regimen. Okay? Yun po yung mga binibigyan ng mga doktor natin na parang mga milks. May specialized milks po sila na sinasabi. Okay. So, yung treatment, just a small overview, parang yan po yung binibigyan natin mga synthetic analogs. Okay. Next. This is your MSUD. Kung kanina, deficient si phenylalanine hydroxylase, dito naman ang mga branch chain na keto acid dehydrogenase. Okay, so ginagamit kasi po yung leucine, isoleucine, and valine. So ito yung mga toxic. Pag dapat hindi sila nag-accumulate, dapat nag-breakdown din sila. But at the same time kasi sa maple syrup urine disease, may deficient po na branch chain, tapos hindi sila naka-breakdown ng tatlong to. So, nangyayari, nag-accumulate ulit sila sa brain and then neurologic symptoms also.
And the whole world will smile at you.
Salamat, ma'am, ha.
Can you
Okay, ma'am.
mute na lang
Salamat,
po
ma'am.
your mic? Okay. So, ito po yung mga maple syrup. Ito po yung most common natin sa Philippines. But at the same time, sa States, meron din po sila. Okay. Tapos, yung maple syrup odor na sinasabi nila, it's just sweet. Medyo sweet lang siya. Likely din sa urine, pero sa sweat din, mas na ano siya sa sweat, lalo na pag ito sa Pinas na mainit. Di ba yung mga babies, medyo mas sweaty sila. Mapapansin niyo po talaga na medyo mas sweety odor siya. So, ito naman mga babies natin really has lethargic. As in, mas mapapansin natin na mas poor feeding sila, vomiting, meron din, hypertonicity, coma, and then yung convulsions. Mas sunod-sunod po. Ang problem po dito sa maple syrup urine disease is we have to prevent the catabolic crisis. Okay? Yun po yung kailangan nating pigilan. So, again, for the MSUD, kailangan lang po natin na i-hydrate sila. Kailangan ng hydrations. We cannot have these babies na maging dehydrated. Kasi lalo na pag mga MSUD patients and they have triggers, alimbawa po may infection, nag-AGE po sila, so all the more that mag-accumulate yung mga isoleucine, valine, and leucine, so all the more na nagka-catabolic crisis sila. But we are trying to prevent this catabolic crisis for them not to further deteriorate. So again, those are the marked elevations. And then the intervention, hydration, IV. Likely po, after we have identified the underlying cause pag may mga MSUD patients, tapos napunta sila sa atin, tapos parang dehydrated, we have to address the underlying cause. So if it's AGE, then we have the proper IV hydration. If it's something pneumonia or kaya meron na silang infection, we have to give the appropriate antibiotics. But for them also, meron din po silang restrictions. No protein din sa kanila. Meron din po silang specialized na sick regimen. Okay? May binibigay din po specifically for them. Mas stricter ang diet ng mga MSUD. As in, very tedious yan sila. So, what we do here, binibigay na siya as milk formula or parang milk preparation sa mga dietitians with proper labeling ng mga leucine levels, isoleucine levels, and valine. So, meron na rin yun. So, nurses, binibigay na lang talaga natin sila per NGT and all. So, treatment, likely nag-hemodialysis o kaya diet supplementation, and later on, pag talagang hindi na natakayan, nag-liver transplantation tayo for severe cases talaga. Okay, so that is your MSUD. This is your galactosemia, okay? Ito yung meron absolute contraindication for your giving breastfeeding, okay, yung breast milk natin. And ito din yung may mga cataracts babies. So, there is a high galactose levels in the blood, and then likely po, ito po ay naging autosomal recessive inheritance. Okay. Ito pala po, pag nag-exam din tayo, minsan tinatanong kung anong klaseng inheritance, yung mga specific diseases. Likely, they're all autosomal recessive unless specified. Okay? Kaltawa ng mga thalassemia, mga X-linked yun, ganon. So, kung hindi natin alam, kung hindi po kayo sure, pero likely neonatal ang problem o kaya pediatric. So, best guess or at least scientific guess or ano nyo is autosomal recessive. Unless, again, specified, unless talagang hindi siya. Pero most likely, autosomal recessive. So, your galactosemia has gut deficiency. Yung gut deficiency natin is unable to metabolize galactose 1-phosphate. So, nagkakaresulta po sila ng injury to your kidneys, liver, and brain. Okay. For the PKU and MSUD, sa PKU po, ang pinaka-damage or magkakaroon ng insult is your brain. PKU. Okay, same as your MSUD, likely your kidneys and your brain also. So, these babies will present to you with lethargy, cataracts, of course, we mentioned that before, hepatic failure, hepatic failure, jaundice, and also can present with convulsions. So, tatandaan po natin yung mga metabolic disorders. Likely, they will present only as seizure. Pinaka-most common sa kanila talagang neurologic yun. So, pag galactosemia, paano natin sila dinadiagnosed? Ayan po. But through confirmation, direct enzyme assay. Okay? So, intervention, we have to restrict no galactose, no milk. Okay? No more galactose in the diet. And then treatment, since wala pong milk ang baby, syempre deficient po yung ating calcium. So, we have to give them supplementations and non-lactose containing milk. So, dyan na po papasok yung mga soy, okay, mga hydrolyzed, mga ganon. Especially or extensively hydrolyzed. Yan. Madami. But be very careful in giving your cow's milk ha, kasi may cow's milk allergy yung sinasabi. Okay. Next is your congenital hypothyroidism. Ito po yung may low thyroid hormone. So again, anong tinitingnan natin pag mga congenital hypothyroidism? Ito very, very, let's say, clinical siya. Makakatch na rin to. If the baby comes into you, tapos medyo sabi ni mommy, jaundice, prolonged jaundice, sabi ni mommy, parang, ay ma'am, napunta po ito, parang nag-jaundice po si baby mga 3rd day of life, kasi peak yun, diba, ng physiologic jaundice, 3rd or 4th day of life. Tapos mga 2 weeks na po siyang may jaundice, but He's able to feed, he's able to move freely, good activity, good tone siya. I know, not good tone kasi ito hypotonic to. Tapos, other than that, wala pong problem. And then when you check the fontanelles open na malaking malaki, and then you check the tongue, malaki din siya. Likely din yung iba talagang mayroong down. But when you see this kid, poor suck, kasi hindi siya masyadong nagdedede, kaya medyo maliit. Jaundice, prolonged jaundice, tapos open fontanelle and large tongue. Likely they are congenital hypothyroidism. Kasi di ba yung thyroid glands nila doesn't function properly. Ano ang most common cause ng mga congenital hypothyroidism? In general, minsan tinatanong to sa local NLE. Pero just for others also to know, baka tanong din sa NLEX. NLEX, traffic. Anong most common cause? Sige, search nyo. Para you have to share it with the group para hindi natin makalimutan. Most common cause of your congenital hypothyroidism. May nakahanap? Okay. Wala ata. Walang wala nag-chat. Is your, ayan, may nag-message.
Iodine deficiency.
For the neonates po, it's not. Iodine deficiency is more common among your mga toddlers, yung mga fad diets. Diba, the baby doesn't need ano pa naman, salt and all. For that is puro more on school age po, iodine deficiency. But for congenital, so isipin natin more of mas organic cause. Dysgenesis po is the term. Yes, underdeveloped thyroid or your thyroid dysgenesis. Okay? I-enter ko po yan. Thyroid dysgenesis. Kung makikita nyo. Thyroid dysgenesis is the most common. Yan. Yan po. Kasi pag, di ba, again, pag diseases, sobrang dami, sobrang broad, kailangan nyo po i-narrow down, okay? Pag mga age group po, para mas mabilis siya. So, pag congenital po, yun. So, properly, hindi, or probably hindi po nag-develop talaga yung kanyang thyroid, okay? So, again, for their congenital hypothyroidism, high TSA, low FT4. Pag tinitingnan po natin dito, pag mga thyroid problems, di ba? Opposite ni TSH. Kung halimbawa, hypothy, ang mataas dito yung TSH. Ang mababa naman dito is yung mga thyroid-free thyroid hormones mo. Okay? And then diagnostic, then of course, makikita to sa congenital hypothyroidism, newborn screening. So, pag nagkaroon po tayo ng mga positive sa newborn screening, again, ano munang gagawin? Iti-treat ba natin agad? There is still confirmatory. Okay? Pag mga newborn screening kasi po, ang NBS is just a screening tool. So, we have to do the confirmatory test, tapos saka po tayo mag-treat. Okay. Intervention, nursing intervention po natin, early detection. Again, kaya ko po in-emphasize yung symptoms natin kasi early detection is the key. Okay, lalo na sa mga well baby visit. Baka hindi lang napapansin nila kasi nga parang normal looking pa rin, but they're really hypotonic, parang sluggish babies sila. Okay, tapos manilaw, medyo, yun yung mga parang pale yellow, yun sila. And then, yung mga bagtang, large fontanelles. Okay, what do we give? Okay, di ba? Kung ano yung kulang, for the confirmatory test po ng, pwede pong it's at the tip at matang. For thyroid, congenital hypothyroidism, ano nga yung test for that? Hold on. Pati tuloy ako na OC na. Wait lang, ma'am, ha? Let's check it a bit para i-share natin. Confirmatory test For different, ano ma'am ha, for different newborn screening, iba-iba din sila. Pero for thyroid, congenital thyroiditis, hypothyroidism, let's check. Para hindi ko na rin na, kalimutan ko lang po. Confirmatory. Scintigraphy. Scintigraphy and your ultrasound. Okay. Yes po. Yan. Okay. And then, again, kung ano po yung kulang, dadagdagan natin, di ba? Kailangan itaas, but we have to meet the normal levels lang. So, what we have to give is your levothyroxine. Okay? That is your drug of choice. Okay? Tapos po ba, pag tinanong po kayo, sabihin sa inyo ng mommy, Mom, do we have to take this every day? For how long? How do we advise po with mothers na meron pong babies with congenital hypothyroidism? For how long? Sorry po? Ano po yun, ma'am? May nagsalita kanina. Okay, lifetime. Kasi nga po yung problem natin is that is genesis of your thyroid. So we have to give it lifetime. But we also have to do, if hindi po tinanong sa inyo, kung hanggang kailan i-advise na si mommy, kung paano po iti-take yung levothyroxine, hanggang kailan, likely din po yung monitoring. So yung monitoring, mga 6 months, for the first 2 to 3 years, every 3 months, ganun. Meron po yan. Pero iba-iba po kasi per, halimbawa sa local. We do it here, pag hypothyroidism siya na newborn screening, scintigraphy, tapos mag-ODS. Tapos after nun, ibibigay na natin yung levothyroxine. We have to give the levothyroxine naman for at least 2 weeks ulit muna. Tapos papabalikin natin, ipapa-levels ulit natin ng TSH, saka FT3, FT4, si mga free thyroid hormones. And then after po doon, babalik po sila ng 3 months for the first year, and then every 6 months, and then yearly after. So may ganun pong interventions when we say monitoring. Pero likely po ang tatanong sa inyo dyan is treatment. Or kaya yung intervention is early detection. Kasi hindi na po ma-reverse din yung pag hindi po natin na-address yung mga congenital hypothyroidism. Mental delay din po talaga. So those are what we're trying to prevent. So your G6PD naman po, so glucose 6-phosphodehydrogenase deficiency. So that is the enzyme deficient. Kasi ano po ang ginagawa ng G6PD enzyme sa RBC? Di ba po? Siya po kasi yung nagbe-maintain ng cell membrane ng RBCs natin, integrity ng cell membrane. Now, if that is deficient, easily po na puputok or naghi-hemolyze yung mga RBCs natin when exposed to mga antioxidants. So, kailangan po, pag may mga G6PD, never po natin sila exposed to antioxidants. So, yun po yung may mga tinasabi natin, mga flavobeans, may mga G6PD diets, okay? So, be mindful lang na kaya yun po yung most common complications is your hemolysis o pagdudugo kasi yun po yung gamit ni G6PD enzyme. Okay, now what are the symptoms? Anemia, 'di ba? Kasi talagang bababa yung hemoglobin. Jaundice, bakit nagkakaroon ng jaundice? Kasi 'di ba yung pag RBC destruction, yung mga heme, may mga bilirubins din siya. So every time that you are bleeding, 'di ba? Hindi rin po siya nagkakaroon ng hindi rin po siya na discard or na-excrete. So it just goes to the different part of the body. Okay? Tapos, poor activity, dyspnea, and then respiratory distress. Kasi likely nga po because of your anemia. So, ano po yung ating diagnostic screening? So, ito po yung confirmatory ulit ng G6. I think it's just the molecular. You just have to pinpoint po na wala po yung G6 enzyme. Okay, that is the most diagnostic. Ay, ano ba yan?
Why are you crying?
So, intervention, avoidance, and removal of triggers. Meron po ba kayo nung sisend ko na lang sa inyo din later. Meron kasi parang tables of what to avoid. Sa antibiotics, bawal po sila ng mga sulfadiazines, bawal po sila ng flavamines, may mga specific antibiotics. So, kailangan po talaga i-emphasize sa mga G6PD mommies to always let their doctors every visit na this kid is G6PD positive or G6PD confirmed kasi there are certain antibiotics, medications, diet specifically na bawal po sa kanila. Kasi if they will be exposed, yun po ay mangyayari. Magkakaroon ng hemolytic anemia, hemolytic bleeding. So, what happens also kung ang mga babies natin ay napunta or na-expose sa mga infection. So, may mga underlying causes din po na pwedeng mag-trigger ng hemolysis. Infection is one, aside doon sa na-expose sila sa mga triggers. Tapos ano pa po? Ito talaga minsan hindi po napapansin. Even up until nagtatanda na po tayo, hindi po natin napapansin na may G6PD sila. Kasi livable naman. Kumbaga, okay lang. There's no interruption of your ADLs. This is livable, but you just have to avoid triggers. Para siyang allergies, no, kung titingnan natin. Okay? So, minsan yung iba ngayon lang ma-realize, sino din po sa inyo dito, yung may mga mahilig sa mga babies, efficacent. Yung green, yellow, di ba meron yan sa atin? Very, very common that, especially to babies na may mga kasabihan, you have to put oils in the belly before taking a shower, or mayroon dito lalagay sa ulo kasi daw yung bumbunan, mahanginan, Diyos ko Lord. Ano pa? Pag may mga masasakit sa di ba you have to put on those emollients or mga oils.
Manzanilla, Dok.
Manzanilla, ayan. Hindi po yan pwede ibigay sa mga G6PD. Lalo na po pag hindi kayo, yung mga dating wala pang newborn screening, hindi pa po nakaabot for the nakaabot ng newborn screening, pwede po kasi silang mag-flare. Okay? They are not okay with like hindi sila pwedeng lagyan ng mga ganun. Meron akong patient before na hindi nila alam na G6PD. Tapos, yung patient na pumunta sa amin ay lethargic na. Tapos, hindi namin alam kung ano nangyayari kasi anything else is okay. Except nung tinatanong kasi namin yung newborn screening, walang mapakita si mommy at hindi niya alam yung resulta. Kasi di ba ngayon tinatawag pag merong problem. Si mommy talaga wala niya alam. So, nagtataka kami. Tapos, lagi lang met acid, yung Tapos, the baby is really not doing okay. Tapos even up until nung nakita namin, naglalagay siya ng manzanilla. Efficacent ba yun ang manzanilla? So nung tinignan namin, Mami, kailan niyo pa po yan binibigay kay baby? Since newborn daw. So nagtaka kami, as in since newborn. So pinatest namin siya for G6PD, nag-positive. Okay, positive siya kasi trigger niya yung mga dihog-dihog. Yung mga...
Pero Dok, kung pinanganak sa hospital, di ba no lahat yan? No oils, no powder, no sinasabi.
Pagka-uwi nila, Mami, siyempre pag nasa ospital, wala lahat. Pero kasi di ba we cannot debunk those lola and lolos old tales. Diba? Mahirap yun eh. Pag sinabing,
yes.
Mami, pag uwi po, bawal na po tayo mag-big kiss. Pag balik mo, Mami, tingnan mo may big kiss. Kasi po sabi ng lola ko, sabi po ni Mama, wala na po tayo medical person, wala na po tayong laban. But we have to really emphasize kung ano po yung importance or what we know at least kung ano po yung hindi safe sa mga babies nila. Kasi mahirap po talaga paano ba yun? Paano ba i-explain? Kasi di ba there are also some non-medical practice na hindi rin ma-explain ng mga nakasanayan. I think that's the term, nakasanayan ng mga lolo-lola. Okay? Di ba? Yung mga hilot. Di ba? Hindi naman natin yun medically ma-explain, but it works. Di ba? Hindi natin alam. Pero yeah, it's the same thing po.
Huyati.
Parang yung mga
Yan na.
bihog-bihog, yung mga manzanilla na
Yes,
yan.
naman
So,
dito, 25.
tinatanong ko na yan
24,
every single
25.
time may baby ako
Wala
na,
to,
lalo na
na.
pag hindi alam na kung walang newborn screening. Tatanong natin yan. Okay? So, yan yung mga most common.
Ayaw ko dahil niya.
Okay. May question dito. Doc, possible po ba na magkaroon ng multiple metabolic problems ang baby? Yes. The answer is yes.
Oo,
Pwede po yan. May babies
Doc,
na po. Ay, sige po.
Hindi na namuto.
Look, when you say newborn screening, hindi yan sa hospital pinanganak, no? Kasi kung sa hospital, automatic na yung newborn screening.
Yes. But there are mommies also po na kahit po sa ospital pinanganak at may newborn screening, they are not very attentive. So, kahit may binibigay sa kanilang newborn screening, di nila nakikip or hindi rin nila natatandaan. Siguro kasi postpartum, di natin alam kung grabe yung labor niya at hindi niya naalala kung saan niya nailagay o anong sinabi sa kanya. So, meron po talaga kami experiences na kahit po hospital na panganak ay wala po kaming makuhang newborn screening from the mother.
Oo, unja.
Okay, Doc. Thank you.
Opo.
Pabalik kong tanaho.
So, unless po talagang dito sa atin, well, ganun, di ba? Pero yun kasing newborn screening is very specific for one patient. Bawal po kasi yan i-share. So, nawawala talaga minsan ng mga mommies. So, again, going back to your G6PD, avoidance lang po ng mga antioxidants. Meron pa akong list na ibibigay. Sige, later on ulit after this day. And then, ano pa po? Supported treatment lang.
Kay, kung
may sakit or halimbawa masakit yung tiyan, we can give medications that are not with antioxidant. Yung pwede po sa kanila. So, minsanan lang po tayo mag-blood transfusion. Kasi nga po, di ba, what we are trying to prevent is the hemolytic crisis, the hemolytic anemia. So, minsan po talaga pag sobrang crisis ng bata, nagba-blood transfusion. So, wala pong cure, just avoidance of triggers for G6PD.
24
Okay, I think we're on the last 6 disease for your newborn screening. Okay, your CAH. Okay, di ba sinabi ko sa inyo to, pag tinignan natin yung genitalia ng baby, when the baby is born, and then you do your PE, nag-anthropometrics na po tayo, height, weight, length, ganun. And then the vital signs, and then you do your physical examinations down to your genitalias. Tapos pagtingin po natin, medyo ambiguous. Pag ambiguous po, di ba sinasabi ko sa inyo, likely the androgens are very hyperactive. So, yung mga female, minsan yung mga females natin, yung mga clitoris nila, medyo hyperplastic, di ba? Malaki. So, hindi natin alam kasi malaki din yung labia majora para napagkamalan natin na testes or scrotum. So, yun. So, this is one of those. So, at least clinical din po. Meron din po tayo mga clinical. So, virilization of female. And then, ito po sila yung mga hypo or hyperpigmented. Hyperpigmented po. Medyo maiitim sila. So, there is a decreased production of cortisol or so overproductions of your androgens. And as a result, as I have mentioned in your physical examination, pag late onset naman po, later on in life, yun yung mga acne, mga irregular menses, and then your hirsutism. Okay, there is just a question I need to address. Doc, when we still perform newborn screening, even few weeks old na ang baby. Mommy, I'm mom. Na-mention ko po on our last meeting that your newborn screening can be performed pag po preterm and then naging stormy course can be repeated after 2 weeks. Okay? But ideally po, hindi na po siya lalagpas ng 1 month. Kasi po, yung ating strip, yung result po niyan or yung values that we are trying to put on doon sa machine, hindi na po yun yung values ng pang matatanda na or beyond infancy. So, hindi na po yun ganun ka-accurate. So, pag newborn, pwede po siyang up until 2 weeks. Pero hindi po yun advisable. The moment po sana na pinanganak, 48 to 72 hours or before discharge, dapat po gagawin na siya early on. Yun po yung pinaka-best. Inuulit lang po after 2 weeks pag preterm and with stormy course. Kasi hindi natin sila mani-newborn, especially pag maliliit, konti lang yung blood, marami pa naka-intubate, or may mga antibiotics, or mga auto support. So those are just the risk factors or instances na pwedeng i-delay. Okay. So, going back to CAH, Ay, okay po. Sige po. And then, ito po yung nangyayari. Bakit ko po ito nilagay dito? Kasi po, ang tinatanong dito minsan, so aside sa symptoms, 'di ba? Parang virilization of female genitalia. So ano po yung sakit? Probably congenital adrenal hyperplasia. Now there is an overproduction of androgens. Paano po nangyayari yung overproduction ng androgens? Ang tatandaan nyo lang po dito is ang deficient po is C21. Itong 21OH. Teka, hindi yata nakikita yung mouse ko. Okay. So basically, kung paano po nagagawa yung ating cortisol, ito po siya. Pero ang gusto ko lang po ninyong tandaan is si 21 tsaka si 17OH. Kasi po, pag nag-diagnostics tayo, ang mataas po doon is si 17OH. Pero ang deficient po is si 21. Kasi 21 hydroxylase is the one deficient in this disease kasi hindi rin po mako-convert 17OH to be your cortisol. So siya po ang tumataas. Okay? So pag sinabi pong diagnostic testing is the 17OH levels which is high but the deficient is the 21 the hydroxylase. Okay? Ayan po. Increased ACTH levels, very high levels are your 17-OHP, and then on the late examination or late diagnostic, your stimulation test. So ano po yung kailangan natin i-prevent? Nursing intervention, prevent adrenal crisis. So pag sinabi po natin prevent adrenal crisis, halimbawa po pumunta sa atin itong babies na to, puro vomiting din. Likely they are vomiting, tapos medyo poor activities, very sluggish, and then hyporeflexive yung mga hypotonic yung mga babies natin. Tapos mga reflexes din nila is more of very, very slug. So, ang kailangan po nating address dito if there are underlying causes such as your very to vomiting. So, AGE, electrolyte imbalances, kailangan po natin i-address yun. These patients are also poor feeding, poor suck, so hindi masyadong naglalatch, konti lang. So again, electrolyte imbalances, sugars, and then fluids. So kailangan po natin i-prevent yung adrenal crisis. Likely po talaga common sa kanila is yung sodium and potassium. So kailangan talagang i-check agad ito. So treatment, again, glucocorticoid replacement lang. So most common na ibibigay natin is your hydrocort and your fludrocortisone. Meron din po itong oral. So, sila baby pwede pong i-continue at home. They can do kasi matagalan din po itong lifetime din po. Matagalan din po itong treatment. Okay? So, again, focus on the intervention, prevent the crisis. Okay. So, that is your IEM. So, mga newborn. Okay, sa newborn, alam nyo, jaundice, hypoglycemia, tsaka yung mga congenital na nasa-screen sa newborn screening. Now, punta naman tayo sa persistence. Okay? So, dito, cardio. May mga cardiac nurses ba tayo na nagpa-practice somewhere? Meron ba dito na magti-take pa lang ng NCLEX? Ayan. So, mayroon kasi ako nag-experience na nagturo ako, tapos cardiac nurse na pala siya sa Middle East. So, alam na alam niya yung mga procedures. And then, maganda yun din yung discussion. So, if ever meron din dyan sa inyo, please feel free to, share your knowledge para mas kasi baka mas expertise pa ni ma'am to, no? So, sa heart failure, sa cardiac po, ang tatandaan lang natin, pag cardiac diseases, yung mga sinasabi natin ng classification, function of your heart failure classification. So 1, 2, 3, 4. Bakit po ginawang ganito? So we are just trying to simplify on how the severity of the patients na makikita natin, yung heart failure symptoms nila. Kasi likely, if there are 3 or 4 na, like severe na po, we can assess that this patient is already in chronic phase. So at least matagal na. Kasi di ba po, pag cardiac patients naman, unless congenital, really is just a chronic situation. So, what we have to know about this is yung mga symptoms nila. So pag sinabi po nating 1, there's no limitation with your ADLs. Okay, wala. As in, kaya pa po nila. But they have a cardiac problem. Likely parang mga konti lang, mga konting butas, konting defect of the heart. But likely po ay kaya pa rin nila to go through with their ADLs without assistance. Pag sinabi naman pong class 2, there is slight limitation of your physical activity. And then, symptoms with ordinary physical activity. Halimbawa po, pag konting takbo lang, takbo-takbo, or kaya ganun, nagda-diaphoresis na, kaya medyo nakakahingal na sila. But still, hindi po yung tuloy-tuloy. Eventually, when they rest, they can still go on. Halimbawa po naman sa 3 and 4, there's already marked limitation of physical activity, and then they already have assistance. So likely po, these patients already has tachypnea, diaphoresis, and then pag newborn po or mga lower babies or mga smaller babies, ang pinaka-common symptoms po natin is they feed poorly. Alam niyo po yung pag nagsasak sila kay mommy, sak, feed, and then titigil. Hihinga muna sila, and then after they hinga, sak ulit po, feed ulit, tapos nakikita natin kahit nagbe-breastfeed, nagpapawis. So likely baka isipin natin may cardiac problem yung newborn na yan. But for the greater or for the older ones po na may mga congenital problems, ay cardiac problems, rinig niyo ba yung baby ko? So, pag mga older babies naman po, tapos or kaya mga adolescent, talagang naka-orthopnic na sila, hindi na po sila nakakahiga flat. Okay, when you ask them, may mga dyspnea na rin silang na-experience, dyspnea or kaya orthopnea, and then mga stress-induced dyspnea. Okay, so ganun po pag 4. 4 talagang bedridden na lang sila. As in, all activities restricted and then with assistance. Okay, most common po na tinatanong sa ating mga exams, hindi po nawawala si RF. Okay, with rheumatic fever, what happens po is that you get this certain infection, either the throat or the skin, likely po throat or sore throat, yung sinasabi natin, na common po ay mga streptococcus. So when this infection ensues, tapos mayroon po mga natitira ng mga infections dito, nagkakaroon po ulit ng sequelae, another complications. So yun po yung tinatawag natin na RHD, rheumatic heart. Kasi after that repeated throat infections, nagkakaroon po ng complications to the cardiac valves. So ang nangyayari, we have to cure or at least on the initial sore throat or skin infection, kailangan na po natin siyang i-treat. Have to eradicate the GABs or yung group A beta. Tapos po, para po hindi na magkaroon ng secondary infection. Okay. So what happens again? Rheumatic fever. Ito po yung sinasabi nating Jones criteria. We have to fulfill the criteria kasi there could be other diseases entity that could be the same, okay? But most common po ito sa mga 5 to 15 years old na would come into you, mga dyspneic, tapos tachypnic, in distress, classification 2, 3, 4, and then you will see na may mga cardiomegaly na. But this patient, when you go to your history, they already have sore throat infection and skin infections. Okay. And then when you do your 2D echo or your physical finding, physical exam pa lang po sa cardiac ay malaki na yung puso, tapos may mga murmurs na. Okay. Going back, the Jones criteria is what's gonna help you to diagnose this baby. So tatandaan lang po natin na lahat po ng rheumatic fever likely with joint involvement. So Jones criteria is also Jones CAFPAL. Okay, yan po yung mnemonics natin. Mayroon pong joint involvement. Okay, more likely po polyarthralgia. And then O looks like a heart, so myocarditis. And for nodules, subcutaneous po. Subcutaneous nodules, your E is for your skin entities, your erythema marginatum, para po siya nagmamapa-mapa. And then your Sydenham chorea, yung mga for unpurposeful movements, gripping hands, milking grip hands, ganon. Tapos, yun po yung major criteria. Those 5, wag niyo pong kakalimutan. Yung pwede lang po dyan stand alone is your Sydenham. Okay? Yung pwede pong stand alone. Kasi pag nag-diagnose po tayo, 2 major criteria. O kaya 1 major, 2 minor. Okay? Pero, pag sinabi po na which among the major criteria of rheumatic fever can only be seen, standalone lang Sydenham chorea po. Okay. Minor criterias, ito po yung ating mnemonics. So, yung increased heart rate, arthralgia, fever, elevated ESR. So, kukuha na tayo ng labs. Yung mga prolonged PR interval, anamnesis of rheumatism, and leukocytosis. So, yung minor criteria likely are combination of your diagnostics and your PE. Okay? So, when we are trying to diagnose po, kailangan meron pong throat culture. Okay, hindi po siya kasama pa doon aside sa major and minor, we have to have the throat culture of the GABs or elevated yung ASO titers natin or your anti-streptolysin titers. And then plus your major criteria 2 or 1 major, 2 minor. Okay, clear po yun. Just take note lang po yung Jones-Kifupal. So ano po yung ayaw din po natin when we are trying to manage or nursing intervention is for us to prevent the sequelae or yung RHD na sinasabi natin. So, on the first infection, treat. Okay po. And then yung prophylaxis natin and also the treatment is your PENG. That is for your drug of choice. Okay. For diagnostic culture, diagnostic examination, I've already mentioned, throat culture, 2D echo, of course, kasi cardiac tayo. Do not forget your ECG and then the other ancillary diagnostics. Okay. Most common, ito po lumalabas din talaga. Laging itong lumalabas kasi para na siyang parang sa States sobrang dami ng Kawasaki. Especially po nung nag-COVID, di ba? Mayroong mga Kawasaki-like diseases tapos may C. So, baka po sa trends ng atin ngayon, lumabas din po ito. So, Kawasaki disease is your mucocutaneous lymph node syndrome. Okay? So, mga vasculitis problems po ito. It affects the walls of your small to medium-sized vessel. And then your unknown cause, wala pa po. Minsan sinasabi po nila, could be a trigger from a viral infection. Could be. Okay? Could be. But hindi pa po iyon talagang well-studied. Common po ito sa less than 5 years of age. Okay? So, just remember, cream. Kasi po, yung mga symptoms po nito ay conjunctivitis. Likely po, bilateral. Yung mga rash po niya, non-vesicular. Tapos po, meron po sa palms and hand din. Sa sole, namamaga. Medyo may mga edema, malalaki yung kamay tsaka yung paa nila. And then you can note that there is clads. Likely your cervical, likely unilateral but more than 1.5 centimeters. Okay, kasi di ba pag normal may mga clads naman talaga, may mga bukol-bukol po tayo dito. We have those lymph nodes talaga. But normally if that is inflamed, that is more than 1.5 centimeters. And then yung mga sinasabi po natin yung mucosal involvements, yung strawberry tongue, and then mga oral features. Okay, just remember cream. So, pag sinabi pong mga small-sized vessels, likely po yung itong most common sa Kawasaki is your coronary artery. So, yun po yung pinipigilan natin. So, again, Kawasaki disease should have this 5. Pero ang pinaka-major po dyan natatandaan, sorry, hindi lang nakalagay pala, fever. Kawasaki disease should have fever for at least 5 days. Fever for at least 5 days. Plus cream, conjunctivitis, non-exudative, your polymorphous non-vesicular rashes, edema of your hands and feet, cervical lymphadenopathy more than 1.5 centimeters, and then the mucosal involvement, si strawberry tongue. Minsan kasi hindi po natin ito makikita. Pero likely po, lalo na si strawberry tongue, di ba? Saan nyo pa makikita si strawberry tongue? Minsan, okay, mga rash. Closely to your Kawasaki is your scarlet fever. Pero ito po, likely talaga may fever siya for at least 5 days. Okay? So, ayan po yan. Red bloodshot eyes, cracked lip or strawberry tongue, high-grade fever, rashes, red swollen hands and feet. Okay? So, ang pinipigilan po natin, nursing intervention is when we diagnose this po, prevent coronary artery dilatation. Okay. Treatment. Ito po yung sinasabi natin na talagang kailangan mabigyan within 10 days. Within 10 days of the symptoms, mabigay po natin yung ating immunoglobulins. And then treat after with high-dose aspirin. And then afterwards, also supportive treatment po tayo. You have to give your mga antipyretics, fluids, kasi yung ibang patient din dito sobrang may mga minsan nag-insulin sila diarrhea, but it's not common, vomiting, you know. They're really irritable lang sila. So what we're trying to prevent is the coronary artery dilatation kasi yun yung baka mag-aneurysm. Baka magkaroon ng problem din sa cardiac. So longer treatment din po ito. Pati po yung pagtutundi echo, okay? When we advise this patient on especially the follow-up, do not forget po, importance of Kawasaki disease is the follow-up and repeat to the echo monitoring. Okay. Next. Next is congenital heart defects. But we have, before we go there, mag 20 minutes or 15 minutes break muna tayo. Okay?
Okay, Doc. Thank you, Doc.
Oh, kasi medyo madugo na itong cardiac. Medyo mas ano siya. Break na, CR break. Guys, andyan kayo?
Yes, Doc.
Okay, okay. Sakto 11. Okay. Until 12. 1 more hour. Sana matapos natin until respite. Okay. Sa congenital heart defects naman po, general rule na lang. Para lang, hindi naman general rule. Parang for me, how I try to remember this is kung asaan po yung butas, 'di ba? Paano ba tayo mag-drawing ng heart? Nagdo-drawing ako ng heart, basically ganito. Teka lang ha. So, wala. May ballpen na lang papel. Hold on. Pwede ba dito pen? Ayan, may pen. Gagana ba yung ating stylus pen dito? Ayan, sige, try natin. Di ba yung heart, sabihin natin square siya. Tapos, heart talaga, tapos square. Labo mo naman, Doc. Okay, para lang mas, oo, para medyo ako kasi hindi ko, di ba, parang for us to really understand physiology, at least we have a better understanding how things go. Kasi anything that is derived from that normal flow, for sure defect, for sure disease. For sure may mali, okay? So, ganun na lang. So, this is your right atrium. Hirap na hirap tayo sa mousepad. Ano po? Okay, RV. Basta po yan na po yun. Sabihan yun. LA. Okay. Tapos yung LV. Diba naalala nyo yung sa ano natin, yung sa fetal circulation, ito naman after na. So basically, wala na yung placenta na ngayon the lungs is properly functioning. So anything, so this is your mga septum. So LA, meron ka tayo dito mitral valve, di ba? Mitral valve. Ito naman dito si tricuspid. Okay. So si right ventricle pupunta kay pulmonary, si left ventricle. Si left ventricle naman, pupunta siya sa systemic circulation. Okay. So, ganito lang po, no? Anything that halimbawa, ang butas natin ay nandito, ventricular. So, ano yung natin dito sa before or after niya? Yun po yung magsasuffer or mag-workload. So, you have to understand na whatever is behind it will be pushing more blood o kaya yung pressure o kaya kung naman ay yan ay maliit. Kung anong pinag-usapan natin butas, so taluyan lang. So magpa-pump lang siya doon tapos hindi siya pupunta doon sa proper chamber niya. Tapos yung affected naman na pinupuntahan niya will also have an overloading. kumbaga overwork up din siya. So ano yung before, ano yung after, o kaya naman pag masyado naman maliit. Stenosis, sinabihin natin. Stenosis, maliit lang siya, cute. So wala naman flow. So di ba kung ano yung nandito na nagpapump sa kanya behind, mas mag-workload din. So ibig sabihin siya yung napapagod, siya yung tataba, siya yung lalaki. Okay? Kasi siya yung nagtatrabaho eh. So ganun lang din po yun. Tapos kung butas naman, so yun din nagre-receive, yun din yung affected. So whatever comes before it, pumping blood, and whoever receives it also has another workload. Okay? So ganun po yung usual natin na paano ko siya iintindihan. So, anything disruption. So, meron ulit dito, may butas dyan, o kaya may stenosis dyan, ganun po ulit. Minsan naman, nandito sa gitna, di ba? Dalawa, affected. Dalawa. Ibig sabihin, atrial and ventricular affected. Merong mali. Okay. So, ganun po yung ating approach for this para mas madali natin siyang maintindihan. Okay. Paano na nga ba ito i-delete? Erase all. Okay, so anyways, ayan. For congenital heart defects naman po, pwede rin po silang magkaroon ng presentation na tinatawag natin kanina ng mga heart failure symptoms. Lahat po iyon, anything na considered or kaya affected yung heart, pwede silang magkaroon ng presentation na sinabihan natin kanina ng mga New York classification, heart failure classification symptoms. Okay? So, for the congenital heart defects po, itatakal lang natin yung mga most common. Meron tayong tinatawag na cyanotic, may tinatawag tayong acyanotic. Okay? So, for all cyanotic po, lahat po ng letter T na nag-uumpisa sa letter T. Ano yung mga T na yun? Na mga right to left shunting. Ibig sabihin yung mga cyanotic. Pinaka-common sa T, alam natin at laging lumalabas sa exam.
Tetralogy of Fallot.
TOF, very good. Okay, sa cyanotic TOF. How about naman po sa acyanotic? Hindi po sila nangingitim or hindi po sila nagbo-blue. Most common is your
Atrial septum defect.
VSD po. VSD, ventricular, not the atrial, okay? Ito po kasi baka malito po tayo. But the most common congenital heart defect, VSD pa rin po. Most common congenital heart defect is VSD. Pag sinabi pong congenital cyanotic is TOF. Okay? Pag acyanotic, VSD. Okay. Sige. Let's go to is 1. Yung mga common lang po ang itatakal natin. But please do your own readings din po when it comes to other cardiac symptoms or diseases. Okay. So etiology, in general, wala po tayong, hindi pa natin ma-distinguish. Likely, pag congenital talaga in utero, pwedeng may factor from mother. Di ba? Hindi natin alam kung meron din mga genetical causes. Pwede rin po iyon. Again, nature and versus nurture. So may mga genetic and environmental causes. Now, pwede din po siyang mga syndromic or chromosomal abnormalities. And one congenital defect can also pursue more. Pwede po siyang one on the other. Pwede po siyang may ASD, meron po siyang BST, meron din po siyang PDA, meron din po siyang kung ano-ano pa. So likely po they can occur one at the same time. Okay? 50% of the Down syndrome has CHD. And ano po ang most common sa mga Downy syndrome? Mga Downy babies. Minsan po lumalabas sa exam. Sa local, lagi po yung tinatanong. Most common cardiac defect among Down syndrome. Baka din po lumabas sa NCLEX. Pag Down syndrome po is your endocardial cushion or your atrioventricular septal defect. Siya po yung dalawa, nasa gitna na malaki. Involved po yung atria and the ventriculars. Okay. Next. Paano lang po natin i-classify? Again, pag nagka-classify po tayo, pag ito, kailangan po natin intindihin both sides kasi hindi lang siya table. But ito yung nakita kong mas madali natin siyang maaalala. Pag cyanotic po kasi, kaya po sila maitim o kaya nagbo-blue is there is a decreased blood flow, pulmonary flow, There be also right to left shunting, and then the blue blood will go to the systemic circulation. So basically, baba po yung pressure sa pulmonary, tapos hindi po nakapunta doon yung blood, so they cannot be oxygenated. So ang nangyayari, right to left shunting po, and then hindi pa sila na-oxygenate going to the other systemic na. So kaya po nagmamanifest ng mga cyanosis. Okay, most common po natin is your TOF, but there are also your tricuspid atresia, yung mga TGA nyo, TAPVR, and such. Okay, so meron din pong increased pulmonary flow na mga cyanotic diseases. So that is your TGA nga and TAPVR. So depende po. Minsan kasi pag newborn or parang in utero, mataas po yung pulmonary pressure pa natin. Kaya nga po, di pa si placenta ang nagiging lungs muna. But as the moment na umiyak, nag-cry, nagkaroon ng oxygen, di ba? Unti-unti po dumidecrease yung pulmonary systemic pressure natin, and then napupunta na po dun yung blood flow. So dun na po nagkakaroon ng flow sa heart na pwede na pong ma-oxygenate. Okay? Pag acyanotic naman po, always remember that it is left to right. Left to right shunting po siya. Okay? So yun po yung mga acyanotic natin, which is your VSD, ASD, ABS defect, and yung PDA. Meron din po tayong mga acyanotic na mga obstructive. Yun na po yung mga stenosis natin. Next. Saan na ba yun? Ayaw niya matanggal. Ayan. So, for congenital heart defects, ito po yung mga common natin na therapy and diagnostic in general. Okay? So, pag sinabi po natin mga cardiac, huwag pong kakalimutan, hahanapin po sa atin, mga nurses, yung mga ECGs natin, di ba? Kung na-order na, ganun. 2D echo and your chest x-ray. Kasi di ba sa chest x-ray, makikita din natin kung mayroon ng cardiomeg. Okay? Tapos insuing din kung may mga lung infiltrates, kita din natin baka cardiac din yung problem, hindi actually yung pulmonary. Okay, for the acyanotic, usually nagkukuha tayo dito ng mga afterloaders or mga preloaders na sinasabi because we do not want the heart to keep pumping lang na overwork up. So minsan natin sila. Dinidecrease natin yung fluid overload. So, nagbibigay tayo ng mga diuretics, kaya yung mga digoxin para naman po tumulong mag-pump din po ng maayos yung puso. So, cyanotic digoxin diuretics, which is your potassium sparing to avoid hypokalemia. Diet po is low in sodium and then decreased auto-demand. For the cyanotic naman po, polycythemia monitoring kasi nga po sluggish talaga sila. Wala yung disrupted yung blood flow, right to left shunting. And then you have to provide oxygen and fluids. Again, your blood flow and your blood is oxygen carrying. So, pag mga cyanotic, most common dito, di ba si TOF, familiar tayo sa knee chest. Okay? To increase the systemic vascular resistance. Okay, so squatting. Ganun po yung ginagawa. Pag ini-squat, knee chest, tataas po yung systemic vascular resistance. So, magkakaroon po ulit ng blood flow. Next, yun po yung parang in general. Pero pag in detailed, punta tayo dito sa acyanotic muna, which is your left to right shunting. So, si left to right shunting, VSD. Again, this is the most common form. Meron po tayong tinatawag na membranous, perimembranous, and muscular types. Yun lang po yung mga types na yun. So, the holosystolic murmur that you can hear, di ba po, pag S1, S2, again, S1, yung unang tunog sa BP natin, ano po yun? It's the closure of your going back. The lub. Why do you hear the lub? How do you hear the lub? Lub-dub. 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 Diba yung closure ng ating systolic? Pag systolic BP ang naririnig, that is the closure of your tricuspid and mitral valves. Okay. And then the dub or the S2 is the closure of your aortic and pulmonary valves, pulmonic valves. Okay? So yun. ito dito po, kaya po natin naririnig lang yung holosystolic murmur. Eventually, nandire-diretso lang. Kasi nag-equate siya. Pag nag-left to right shunting siya doon sa butas na nasa ventricular side, which is here, being showed, imbis po na maririnig natin yung closure ng S2, anong nangyayari? Nagba-blood flow pa rin kasi. Di ba yung mga blood flows kasi sa mga butas is naririnig natin because of the turbulence. O kaya yung blood flow, yung pressure na dumadaan doon, yun po yung nagkakos ng murmur. Kaya po may mga naririnig tayong extra heart sound. Okay? So pag maliit yung butas, di ba, mas pressure, mas malakas kasi maliit lang. Pero pag malalaki, halos wala kang marinig na murmur kasi nga parang dire-diretso lang yung blood flow. Okay. So ito po, na-equate kasi. Instead na maririnig mo na yung S2 niya, likely kasi pag nag-blood flow na, nag-lab ka, naririnig po, hindi natin na marinig masyado yung S2 kasi nga yung blood flow nito dito sa may ventricular side. So parang nagho-holosystolic. Iisa lang niya naririnig natin sa S2. Kaya naririnig natin lang halos S1 lang tuloy-tuloy. Kaya po siya sinasabing holosystolic murmur. The smaller the defect po, the earlier the symptoms and louder the murmur. Okay? So yan po sila. Even the ASD, VSD, yun po. Yun din po yung maririnig natin. Or the reason behind why is there symptomatic patients and asymptomatic patients na but later on nagkakaroon pa rin po ng heart failure signs. Okay? So again, for VSD, ang tatandaan po natin, it is the most common form presenting with holosystolic murmur. And then the smaller the defect, the earlier the symptoms that will ensue, and then the louder the murmur it is. So diagnostic, again, it's the same thing that I have mentioned kanina. And what are the intervention? We give them anti-congestive therapy kasi more likely they will congest. Pulmonary congestion po ang problem natin dito kasi yung volume pupunta lang agad sa right ventricle going to the lungs. Okay. So mas na malaki yung defect, mas malaki yung defect niya, mas malaki yung butas natin. Mas madaming blood flow na lang pupunta sa pulmonary. Okay? So, usually po, ang lahat naman talaga ng cardiac patients are presenting with failure to thrive. Likely po, they will present failure to thrive. Poor weight gain, tapos easy fatigability, tapos yun nga yung mga ang tawag nito is fatigability, mga deferesis ng mga babies. Sa mga smaller, again intermittency of feeding sila. Yung sinasabi natin sa mga older child na easy fatigability when it comes to smaller children, yung intermittency of feeding. Okay, so kailangan po natin ng nutritional support. Okay, bakit po in nutritional support? Kasi kung makikita nyo, yung treatment natin for this cardiac patients is surgical. Okay, pero pag mga maliliit po kasi, lalo na pag ilang kilos lang, we really don't go into procedures or opera agad when not reaching the optimal development of a baby. So that includes your weight gain. So kailangan may weight gain o kaya gaano kalaki yung defect, may mga criteria din po. So for us nurses, we have to make sure that the patient with VSDs do not ensue congestion. And at the same time, upbuild pa rin po natin sila, which is nutrition-based. Okay? So, surgical treatment, tas yung valve closure, meron na po tayong mga tinatawag ngayon sa mga gustong mag-cardiac nurses in the future, specialized. Very high-tech na ngayon. Hindi na po tayo nag-open chest. Mga femoral catheter device closure na lang po yung mga ginagawa natin. So, parang minor procedure na lang nga po ito. So, again, yung iba, by 6 months, usually pag talagang heart failure symptoms are very evident na, and then the baby is failure to thrive na sobra, at anong upbuild natin, hindi makayanan kasi nga malaki yung VSD niya. So we have to correct this as early as 6 months. Pero likely po at the 12 years old dapat. Pwede pa po. 12 months pala, 12 years old. 6 to 12 months. Yung device closure. Okay. Sa ASD naman po, ang nangyayari, nasa atrium. Atrium naman po yung butas. Same thing. Same thing po, depende po sa liit o sa laki na maririnig natin yung murmur. Naman po dito regarding the ASD, most common form nila is secundum primum or sinus venosus. So yun yung may mga types din tayo. Tapos, ang nangyayari po dito, ang lumalaki, diba? Tingnan mo, kung si right atrium ang defect niya, ang lalaki po dito is your right atrium and yung left atrium. Kaya po ganyan. Okay. When you notice dito sa, sorry, hindi ko na-mention kanina. Sa BSD nyo, ano ang lalaki dito? Tingnan natin yung left ventricle. Okay. Left ventricle and your right ventricle din. Same thing with your ASD. Tapos, ang tandaan natin dito with ASD is your splitting. Bakit dito may splitting murmur? The splitting murmur kasi accentuated lang siya because of the tawag nito, the AV valves. The AV valves and your P valves, your pulmonic. Kasi your ASD, usually po, dito, hindi mo masyadong maririnig na yung S1 naman. Yung S2 naman, parang siyang accentuated, parang, ano ba to? Parang instead of a splitting, may maririnig kang another murmur. Parang galloping. S3. Pero likely, it's just that S2 split lang siya because of this butas from the atrium. So, ang affected natin dyan, actually yung pulmonary again. So, again, yung pulmonary congestion ang i-avoid natin dito. So, again, anti-congestive therapy, nutritional ulit, kasi surgical po ulit, device closure. Pag ASD naman po, likely, meron din talaga silang up until 1 year or 2 years old, depende po sa laki ulit ng defect. Tapos sa symptoms also, symptomatic approach din po sa babies natin. Yung iba kasi pag maliliit lang, di ba, they can still go on and continue with their daily lives. Tapos minomonitor na lang to the echo, siguro mga 6 months. Tapos tinitingnan natin kung kumusta yung baby. Hindi ba mas hingalin? Tapos tinitingnan din po yung murmur kung mas nag-aggravate. Likely po talaga hindi sila mag-thrive, but we have to very assess or advise the mother na kailangan po talaga proper caloric intake. 'Di ba yung mention ko sa last lecture ko na mayroon tayong per age group na total calorie na kailangan nilang i-intake. Same thing po din po yun, all the more that it should be followed, especially with cardiac patients. Kasi you have to optimize them for the treatment, for which is the surgical. And please, yung hindi sila magkaka-infection. Kasi pag nagka-infection sila, di ba, all the more na hindi matutuloy-tuloy yung ating, hindi matutuloy yung kanilang OR. Okay. Sa aortic stenosis, kung makikita po natin, ito, si number 8. Yung murmur po na yan, talagang maririnig nyo because of the turbulence or mayroong hindi makapasok na pressure all going to your aorta. Okay, so there is a very little passage of the blood flow. So, hindi enough yung volume. So, anong nangyayari po, di ba? Sino ang nagpa-pump? Sino ang nasa behind it? Si left ventricle. Si left ventricle, hindi siya makapump ng enough blood going to the aorta. So, magwo-work magko-contract na magko-contract. So, ang nangyayari, na overworkload siya, then the left ventricular muscle will mag-hypertrophied. So, kaya ka po, pag AS, very, very prominent ang LVH. Kung makikita nyo, LVH will be manifested na parang upslanted sa X-ray. Hindi na po kita yung apex. Kasi tumaba na siya. So, parang naka-upslant na lang siyang konti. So, that is what happened with aortic stenosis. So, maririnig mo yung murmur because of the very, very small passage as yung pressure plus the LPH. Same thing with your pulmonic stenosis, there will be RVH kasi po ang mag-work naman po dito yung right ventricle going to the pulmonary circulation. So, ang mataba po dito, ang nag-hypertrophied po is your right ventricle. Okay, just a very ang COA very specific with this one is there will be a differentiation of your BP monitoring. Okay, pag baby smaller, madaming IV dito sa kamay, where can you take your BP? Siyempre, mag-monitor po tayo ng vital signs, especially pag mga cardiac. Saan po pwede ilagay si blood pressure or BP cuffs? Sorry, si BP cuffs natin. Okay, in the lower extremities. Thigh or lower extremities. Okay, pwede po doon. But, yung difference po, higher or lower usually ang lower extremities compared to the upper extremities?
Lower.
In a normal.
Lower.
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 Ay.
Teka, naglalagata ito. Tinitingnan ko kasi yung chat box. Ayan. Sorry. Higher po sila ng mga 10 to 20 millimeters mercury. Okay? Medyo mataas po ang legs. Okay. Pero sa ano po yan, sa leg lang po yun. Kaya hindi po tayo masyado nagtitake ng BP in the lower extremities. We also get it on the upper, especially po on the left na mas closer po to the heart. Okay. So, pwede pong mag-BP sa lower extremities. Now, if you take your blood pressure in the legs, and then you check it also with your upper extremity, mas mataas po si lower extremity na more than mga 30. Okay? Mas mataas po ng mga more than 30 millimeters mercury. Saan po yung tinatawag natin na difference of the upper and lower extremity BP plus pag kinapa niyo po yung mga femoral pulses niya dito sa kamay tsaka sa femoral part, sa cephalic or sa brachial, bounding po. Kahit po sa may dorsalis pedis, bounding pulses po sila, especially po sa paa. Okay? So, ang intervention po dito is your end-to-end anastomosis kasi kailangan po natin i-close yung aorta. We have to go, mali po kasi talaga yung daluyan niya. So, end-to-end anastomosis will be done with these patients to have another route for the tawag po nito, to the left ventricular to go on throughout. Kasi nagkadiretso na siya sa LV, di ba? Nakadiretso na siya agad sa LV. So, kailangan po ng another route for that before po pumunta sa systemic circulation. Next po, pero dito okay lang po yung BP. Wala pa tayong gagawin doon. Intervention with that one is we have to correct the defect. The difference between the blood pressure is wala po tayo doon until the defect is being treated surgically. But again, we can give mga improved contractility such as digoxin or mga afterloaders or preloaders as such. Kasi mas evident yung cardiac symptoms nila, especially for your COA. Okay? And for your COA po pala, dapat mas correct sila early on, unlike your ASD and BSDs. COAs need to be corrected early onset. Okay, let's go to cyanotic. Sa cyanotic, again, you just have to at least master ASD, VSD. And then the two stenosis, okay? Parang yun naman yung mga most common na lalabas sa inyo. Pag cyanotic, right to left shunting, okay, hindi mawawala. Ang pinaka-favorite nilang TOF. Just remember PROV. Okay? Components po yan ng tetralogy of Fallot. So, pag sinabi po natin PROV, that is your may pulmonic stenosis. Andyan na po si PS, nasa number 2. Si RVH, kasi po diba, pag may PS tayo, ang nag-work masyado is si RV. So, tataba. So, meron ka ring RVH, which is your dito sa may red. Ay. And then yung number 3 is your overriding of the aorta. Okay, overriding of your aorta dito. And then your VSD. Meron pong mixing dito ng defect, another VSD. So, ang mangyayari po, with this one, nagkakaroon na po ng mixing ng blood even without going to the pulmonary circulation. Pumupunta po agad siya sa systemic circulation. That's why very evident yung ating cyanosis. Kasi hindi pa po na-oxygenate yung dugo. Tapos, nagpupunta na sa different parts of the body, which explains your peripheral and your central cyanosis. But most common po dito, yung po yung tinatawag natin na nagtetet spells. Okay? So, please do not forget your probe. Minsan, nice to know lang to. Meron silang sinasabi na fifth component of your TOF. What is that? Nice to know lang, hindi to zebras. Basic, parang additional info kasi parang lumabas lang dito sa quiz namin before. But I would like to share it to you also. Yung fifth component ng TOF is your ASD. Minsan daw may mga nakikita silang TOF nowadays na mayroon na ding ASD. Okay. So sa TOF, ano nga yung makikita natin sa x-ray? Anong shape ng heart na very prominent? Sasabihin dun sa question nyo. Patient come in, 3-day-old male with ganitong vital signs with circumoral cyanosis and then peripheral cyanosis more evident during crying. Tapos sasabihin nila when you took the x-ray, tapos ganun yung shape ng heart, and then when the 2D echo, may probe. So likely TOF na siya. So ano ulit yung makikita sa x-ray? Baka lang din tanungin kasi prominent with this TOF. Yung shape ng narinig nyo na to? Okay. Boot shape heart. Okay. Boot shape po. Ano ba yung tama ba yung spelling ko? Yung parang ganun. Minsan yan yung lumalabas tinype ko na lang kasi baka i-judge nyo kung magkamali ako ng pronunciation. Then joke lang. Para maling ako, andyan pa kayo, nagbabasa din. Ay, nasend ko kay ma'am, bakit siya naka-private message kay ma'am? Weird naman. Sinesend ko na lang dito guys, kasi baka nga i-judge nyo ako na, hindi ko alam, Coensebo. Sabo. Basta parang French term ba yan? Yeah. So, it just means that boot shape heart. So, pag nakikita niyo po siya sa x-ray, prominent yung RV. So, talagang pag dito sa RV niya, parang siyang balloon. And then dito, sa LVH, meron pa rin siyang pinpoint kasi wala naman tayong LVH, di ba? So, hindi pa siya ma-upslant. So, parang boots po siya. Tapos, medyo dilated, hindi talaga medyo dilated din yung aorta. Kasi di ba meron din siyang overriding. So, para siyang nag-equalize lang. Malaki dito, laki dito. Tapos, parang siyang boot shape. Try nyo mag-send kung sino ang pwede maka-research dyan at i-share natin sa group. O what is the itsura ng boot shape. But you can just search it online later on. Okay, so again, diagnostic 2D echo vary. Confirmatory natin talaga is 2D echo, ECG, and then X-ray. X-ray is your boot shape, and then the intervention. Okay, pag meron kayong nakita na nagte-TET spell, TET spell ha, nursing intervention, first thing to do is knee chest. Pag smaller babies, paano nyo gagawin? Smaller babies, neonate, di ba? Congenital, mabaliit pa. Few days old, 10 days old, mga ganun. Infant, neonatal, anong gagawin nyo? Paano nyo gagamitin yung knee chest? Ha? Paano natin gagawin yung knee chest? Okay, ayan si boot shape heart. Si knee chest, pag maliit po, isa sideways. Sideways po natin si baby, maliit na maliit, sideways, and then fetal position. I-curve po natin sila. You put it in side lying, tapos i-curve po natin sila. Para fetal position. So, at least po, para silang nag-i-squat. Okay, tama. Para pa sila nag-squat o kaya yun yung knee chest nila. Just bring the knee closer to the face na lang. Okay, tapos yun. To increase the systemic vascular resistance. All right. So, usually po ang mga TUF, meron po kasi silang ang underlying cause. Usually po ginagamit namin yung left side kasi po para hindi ma-impinge yung inferior vena cava and superior vena cava para po yung return ng blood to the right atrium. So left side lying and then yung fetal position. Okay. So again, di ba po pag TUF, lagi po silang may mga prostaglandin E1. The TOF, when we say TOF, di ba you have your PDA. Your PDA dito, or not all of them. Kasi, di ba I have mentioned earlier na pag isang defect, pwede pong meron din kasama na mga defect. Okay, so para po magkaroon ng flow, papunta po sa pulmonary flow, minsan po yung mga TUF na babies, meron po silang PDA. So that is the alternative route for them to have an oxygenated blood. So first thing, so binibigay po natin yung prostaglandin. After knee chest, we have to give your prostaglandin E1. So what does prostaglandin E1 do? Nagsusmoothen po siya, nire-relax po niya yung prevention na mag-constrict yung smooth muscles, smooth cardiac muscles. So to keep it open. Okay, we have to keep it open kasi po, yun po yung mas magkakatulong sa kanya magkaroon ng oxygenated blood. Now, the definitive treatment pa rin po is BTS also is just an initial OR. Okay, there's still more definitive na OR pero ang nursing intervention po natin for mga cardiac patients is to keep them, tawag nito, hindi po mag-congest. No congestion and prevent po talaga sila na magkaroon ng death spell. So always knee chest position, tapos elevate the head, yun po yung ginagawa natin. And then prevent infection kasi once they get infected, it's another trigger for them na magkaroon ng death spell. So ayaw po natin itong mga babies na to na umiiyak. If they get too agitated, iiyak sila ng iiyak, all the more na hindi nagkakaroon na, di ba nangingitim talaga sila pag umiiyak sila. So, also, kung itanong sa nursing intervention, ililimit po natin yung stimulation, especially kung may mga blood draws, magkukuha, or kaya kung ano pang, di ba? So, very limited. So, as much as possible, hindi natin sila ina-agitate. Okay? But the definitive is still OR, surgical treatment. But the most important dito, kung may PDA, administer prostaglandin E1. Okay, your TGA naman, di ba? Nagkabaliktad lang po. So basically, meron din po siya mga associated na mga defects, which is your ASD, VSD, and PDA, which is okay. Kasi po, doon po tayo ulit, again, for them to be oxygenated and hindi po masyadong toxic, they have to have another route. Importante po magkaroon ng pulmonary circulation, at least get oxygenated. Kasi pag hindi po talaga, di ba, nagkakaroon lang ng deoxygenated blood, tapos napupunta na agad sa systemic, all the more na wala. Hindi sila inadequate yung kanilang blood supply or oxygen supply as well. So, pag ito pong TGA, mayroon po siyang mga ASD, VSD, and PDA, some of which we have to keep it open. Okay, we have to make sure kung ano pa po yung pwedeng ma-keep open para po meron pating circulation. Okay, now, ito talaga kailangan ng arterial switch. We have to switch them. Okay, OR po. But again, for those na may OR, optimize. So nutrition, nursing intervention pa rin, nutrition, upbuild, prevent infection, tas kailangan talagang ma-achieve natin yung weight nila. So, balloon septostomy po ang ginagawa sa kanila. Ito po yung most common, yung rush kind. Arterial switching is the corrective. So, pag initial pa lang, balloon septostomy, and then later on, pwede po silang again mag-OR for the most corrective or definitive management. Okay. Tricuspid, very rare to itanong sa inyo. Okay. Very, very rare. But just for you to know, ito po, wala po tayong tricuspid valve. So, dumidiretso lang po tayo dito. Meron din po siyang associated na mga other defect, which is your ASTV, STPDA, and there is your RV hypoplasia. Wala. Yan po. Minsan ito siya. So makikita nyo, nagmi-mixing na yung blood dito pa lang sa heart. Hindi po dapat, kasi ang mixing po talaga dapat ay nasa lungs. And you see that the aorta is enlarged.
Okay.
Management po, ito po ay Glenn Shunt and then the Fontan. But again, focus on the nursing intervention, prevent congestion, upbuilding nutrition,
Okay.
prevent infection. Okay, that is for the cardiac. So very short na lang ata tong respiratory. I think ginawa ko tong table for the respiratory system. Ayan. Para mas madali maintindihan, okay, 3 sakit. Pinaka-common po ito sa mga congenital. Ulit, sa bagong panganak. Newborns, neonate, here are the most common, which is your respiratory distress syndrome or your other term for hyaline membrane. Narinig po natin yun, hyaline membrane. The next is your transient tachypneic. Okay, and then the PPH ensure persistent pulmonary hypertension. Okay. Pag sinabi po natin RDS, TTN, and PPHN, halos po magkakasabay po silang presentation nila is distress. Pagkapanganak po nila is respiratory distress. However, makikita po natin, mananarrow down natin to. Yung mga sakit nila, depende po sa risk factors or kung paano po nagpo-progress yung symptoms. Halimbawa, I have discussed before sa inyo kung ano yung preterm and postterm, di ba? So, RDS and your TTN, most common sila sa mga preterm. TTN, pati sa normal, sa term, pwede rin po. Sa PPHN naman po, most common to sa mga post-term, yung mga nakalunok na ng meconium, nakapag-aspirate na po ng meconium. Okay, when we say naman po sa symptoms, okay, sa symptoms muna tayo. Pag RDS, within minute, they will present as grunting. Okay, that is breathing through a closed glottis. So, pagkapanganak, RDS, meaning po toxic o kaya hindi talaga sila naghihinga na maayos, tapos may grunting pa. Likely po preterm din sila. You think first of probable RDS kasi hindi pa po nag-mature yung kanilang surfactant. Okay? So, the alveolar or the pulmonary surface tension nila sa alveolar is not yet developed. So, medyo po collapse. So, kailangan pa natin silang i-open up. Ngayon, pag TTN naman, especially pag term, makikita po natin na early onset, nakalabas okay, pero later on parang may sort of tachypnea or distress. But at the same time, if you give oxygen or minimal O2 support, nare-resolve agad after 3 days. Pero pag RDS po, nagpro-progress pa siya. Magpipik pa lang siya on the 3rd day. Ibig sabihin, pwede pa po siyang mag-crash. Okay? Pag PPHN naman po, within 12 hours of birth, nagpe-present sila ng cyanosis kasi po wala po yung VQ mismatch na sinasabi natin. Ventilation circulation mismatch doon kasi pag PPHN, sample po yung meconium na aspirate. Na-aspirate yung meconium and then the meconium lodges to the alveoli. So, nakabara siya doon. So, may fluid. So, instead of it will be air, fluid po yung nandun and it's, diba, it's septic part na siya. So, ang nangyayari, hindi din na-oxygenate yung bata. Likely, they will present cyanosis. So, ang PPHN din, matagal pa ang course. Hindi pa rin po natin masasabi kasi pwede rin silang mag-deteriorate. But compared to RDS, mas better po yung chance kasi they will improve din after on 3 days lang. Pag PPHN po kasi, we have to address the ensuing increase in pulmonary pressure. Kumbaga, nag-hypertension sila because the pulmonary pressure is super high. So, nagko-congest lang yung bata. Nagko-congest. Bumabalik lang yung pressure going through the heart. Okay. So, yung X-ray, okay lang yan. Just as nice to know kung para lang din may ano kayo, pero hindi naman na yan more of a nursing thing. But I just put it there para din ma-differentiate just in case sabihin dun sa question kung anong type of x-ray. So the course I mentioned earlier, progressive yung RDS, magpipick pa lang on the 3rd day and then saka sila magnanadir, mag-okay. Pero TTN likely second, 3rd day dapat nawala na. Okay? They will recover from a very, very minimal intervention lang. Kasi ang TTN lang po, merong fluid pero hindi lang nailabas. Pero after on, na nakahinga na sila, umiyak na sila, tapos nagaano na din, na magiging okay na rin sila. More din sa CS, kasi ang CS ang nangyayari, di ba, nagbibigay tayo ng anesthesia. So, yung anesthesia, pwede rin pong maging maternal factor siya. So, can ensue fetal distress. Okay? So, how to prevent? Pag mga RDS, syempre, immature yung lungs, we give them surfactant. Okay, replacement. Tapos mga auto support as well. So, inantay lang natin mag-develop or mag-mature yung kanilang lungs. Pag TTN naman po, likely supplemental lang ng auto. Usually nga mga 2 days, 1 day lang nag-low flow, tapos tinatanggal na namin. Okay na sila. Supportive naman po yung sa PPHN. Again, most common causes are MAS. So, we will give them antibiotics, oxygenation. Iba po dito ay talagang intubated kasi talagang in-distress sila. But again, for this PPHN, ayaw din po natin silang matrigger. Kasi pag masyado silang agitated, masyado silang na-stimulate, ayan, all the more that they cry, tataas lalo yung pulmonary pressures nila. So, treat the underlying cause. Pwede din po kasi magkaroon ng PPHN when it comes to bad neonatal pneumonia, mga large or complicated heart defects, pwede po mag-PPHN din. But most common pag mga newborns ay MAS. Okay. So, ito. Lagi ito itatanong. Bronchial asthma. Okay. Ang bronchial asthma natin is very well known, hyperactive airways na po. And it is a lower tract infection. Okay, more of a lower tract infection siya than an upper. So, chronic respiratory condition due to hyper-responsiveness to irritant or triggers. So, ang nangyayari po, once na expose yung patient natin or babies natin into triggers, so all the more that ang nangyayari sa asthma, to the alveoli, nag-hyperreact. And then hyperreactive, nagkakaroon ng mga mucus production, tapos nagbabara. So that causes the obstruction. So all the more that once there is production, overproduction, and hyperresponsiveness to airways, kaya po tayo nahihirapan huminga yung mga may asthma patients natin. And then, dun po meron nagkakaroon ng wheezes because of that obstruction. So there are extrinsic and intrinsic factors. So, pwede siya non-atopic or atopic. Parang same thing. Okay? Most common. Pag tinanong sa ano ang most common atopic or extrinsic cause of your bronchial asthma? Most common.
Smoke.
Dog. Okay. In-house pets. Pero po, kung ang isabihin po natin ang choices ay dog, dust, pollens, or
Dust, Doc.
okay. Sa NCLEX po, dust. Okay. Pag tinanong kayo sa NCLEX, ang pinaka-common po is dust. Okay. Okay. Sige. Next. Ayan. May triad lang po ang asthma, bronchoconstriction, air obstruction, and mucus production. So, na-mention ko naman po yan mamaya, kanina. So, what happens naman po kung silent lungs? Ibig sabihin, wala na kayong marinig. Is it a good thing or a bad thing?
Bad.
Bad thing.
Okay. Why? Bakit siya bad thing? Pag sinabing
Included na.
occluded na po. Kaya po talaga pag mayroon po nursing intervention for any respiratory cases, especially asthma, papakinggan niyo po yung breath sounds. Huwag niyo po talagang kakalimutan. Aside po when you take your normal, your vital signs, please do not forget to listen listen to the breath sounds kahit lang po dito. Kasi talagang pag yan nag-close na, totally wala na kayo marinig. Wala. Asthmaticus na po tayo. Okay, that ensures complete obstruction. So, silent chest is a no-no. Okay. Signs and symptoms, distress, wheezing. Wheezing, inspiratory, expiratory. Sa asthma. Yung parang-
Expiratory.
Expiratory.
Expire.
Okay, very good. Yung mga pusa ha, yung mga pusa, yan yon sa asthma. Okay. Si inspiratory stridor, kanino? Inspiratory. Kanino siya? Most common sa mga ganun. Bronchiolitis. Okay? Common siya less than 2 years old. So, yan yung mga magkakapinsan, magkakapatid, mga magpipinsan. Okay. So, yung mga dry cough din. Minsan kasi isipin nila, baka pneumonia, hirap huminga, distress. Pero always, ang tatandaan natin, pag bronchial asthma, ano sa history? Ang laging tatanong.
Allergies.
Allergy.
Ano pa? Allergies and
Family history.
very good. Family history. Hindi po yun mawawala. Okay? Do not forget to ask kung may family history aside sa triggers or allergies. Okay. So, sino na ang nakapag-try dito ng peak flow meter? I just included this one kasi baka sa exam, ang tatanong po is, how do you diagnose asthma? Ang diagnostic po ng asthma ngayon is based on the GINA guidelines po ay yung family history, tapos yung may known triggers, and then pag nag-respond po sila sa trial na short-acting, ibig sabihin pag nag-salbutamol ka biglang umukay siya, pwede po yung diagnostic. Pero meron din po tayo peak flow meter. Okay. Ito po yung nagme-measure ng expiratory capacity of the lungs. So, yung para hindi nyo na lang tandaan talaga yung mga levels nito. Just know that ang normal is 80 to 100. So, anything below that is not okay. So, just for you to know, yung peak flow po, di ba? Yun yung pinapablow natin sila sa parang may flange. Tapos, may bola. Tapos yung bola po ay pupunta akyat-akyat. Tapos, then po natin i-measure yung 3 best of ulit, 3 best na kaya ng patient natin. And then that's where we record yung pinaka maganda niyang reading. Okay, so just to reiterate kung bakit ko to in-include. So, pwede din po kung may tinanong what is the device used for diagnostic of the asthma, it's your peak flow meter. Minsan tinatanong, minsan din po hindi. Minsan naman po ang tinatanong kung normal o hindi yung ganitong levels. Or what, ano yung mga considerations for you to know that this patient is experiencing asthma. So, pwede po yung mga na-mention natin kanina. Pero likely po ang itatanong ay yung known allergies. Huwag niyo pong kakalimutan. Management. Ayan. Pag-management po, breathing exercises, di ba? Breathe in, breathe out. Inhale to the nose, breathe to the mouth. Rest and hydration, medications. Now, lahat po ay mayroong sinasabing reliever and controller. So, pag meron po tayong asthma attack, yun po yung ating mga reliever. So, yung mga short-acting natin. Sa Pilipinas, ang lagi nating gamit, salbutamol. So, pag nag-NCLEX po kayo, please take note of these medications. Bitoletrol, isoethérine, kasi baka po yan ang lumabas sa exams nyo. Okay? Tapos, steroids. Okay. We have to give steroids kasi po to counterattack their anti-inflammatory. Yung mga obstructions and inflammations doon sa ating alveoli. So, we give budesonide and prednisone. Okay? Tapos, minsan po ngayon, di ba napansin natin yung mga seretide, ano pa ba? Yung may mga kasama na inhaler, 2 gamot na yung nandoon sa isang inhaler na yon. Okay? May steroid component na yun, tapos meron na rin siyang short-acting. Okay? So, depende po sa case ng patient nyo at kung ano po yung pwede natin ibigay. So, yung mga chronic, tapos siguro talagang well-known. And then pag nag-asthma attack sila, sobrang mas malala or kaya mas severe. And then it's difficult for you to manage the attack. Naka-Montelukast na rin yung iba yan, di ba? Mga naka-Leukotrienes na. So, pag hindi po Montelukast, Zafrilokast is the one being used as tapes. So, again, please pag nagre-review po kayo ng Saunders nyo, i-familiarize nyo po. Pagdating po kasi sa mga diseases and medications, medyo magkakaiba po tayo dito ng mga meds, mga names. Okay? So, example ko, mga paracetamol, mga acetaminophen sa kanila doon. Okay? So, ganun. Para lang hindi kayo malito. So, again, management, metered dose inhaler, yung sinasabi ko sa inyo. So, how do you use your inhaler? Paano natin po ina-advise ang mommies or ang patient? Halimbawa, mommies, kasi kung maliliit na bata, kailangan pa ng assistance ni mommy. How about naman po kung, let's say, mga 6 years old na. Yung peak flow meter pala, it's 6 years old and above ha. Hindi siya pwede sa mas maliliit na baby kasi they will not, di pa sila maka-follow na instructions to blow hard. So, sa metered dose inhaler, diretso ba? Sino nanood ng House? Nakakatawa. Ano lang, may patalastas.
Deep breathe.
Sino nakakita sa inyo nung House episode na nagalit pa yung patient, di ba? Nagalit yung patient kay Dr. House because bumalik daw siya after niyang bigyan ng inhaler kasi hindi daw siya gumagaling. Tapos, so sabi ni Dr. House, okay, show me how you use your inhaler. Can you show me how you use your inhaler? Tapos, nagalit ulit yung pasyente. What do you think of me? Do you think I'm stupid? Sabi niya, guys. Sabi niya, do you think I'm stupid? Sabi naman, hindi. But I just want you to show me how you use. Tapos, guys, dito niya in-spray. Diba?
Ginawang perfume.
Perfume ang peg.
Oh my gulay. So, wag po tayong magpapauwi nang hindi na-demonstrate, na i-explain ang mga gamot. Unless mga tablets yan, okay, general rule, universal, sige, inumin. Pero meron din mga tablets, di ba, na per rectal, suppositories. Kaya very, very careful tayo na mag-advise. Kasi katulad yan, inhaler. Paano ginagawa yung inhaler? Inhaler, ano pa ang dapat meron sila? Have you heard of spacer?
Spacer. Ayan.
Spacer, yes. May spacer po ha. Kasi ang tendency, if you do it directly, yung gamot po is nasa oral mucosa lang, nasa oral cavity lang. Hindi po siya pumupunta up until your lungs. Kailangan po siya ng lungs natin, hindi po ng ating bibig. Char. So, mayroon po tayong meter dose, we have a spacer, and then you instruct the patient to inhale, exhale 3 times. Inhale, deep breathe. 2. Pagdating po ng 3, hold your breath, press. Okay, nakuha po iyon. 3 breaths, deep breathing. 2. On the 3, hold your breath, press your meter dose through the spacer. Saka po huminga. Kung kaya pong mag-hold up to 2 to 3 seconds na inhale, kasabay po nung pagbigay ng meter dose, then the better. Para po magdire-diretso pa yung gamot sa ating lungs. Hindi po agad ma-expired. Okay? Tapos, afterwards, kailangan po mag-gargle. Mag-gargle ng mouth care. Kasi nga po, meron pang nagtitira dun na mga medicines yung sa meter dose natin. So, we have to gargle our mouth, oral care. Do not forget to advise. Ha? Okay, so yun po. For the bronchial asthma. Cystic fibrosis. Kung tayo dito may TB sa Pilipinas, may cystic fibrosis din po sila doon. I mean, just the comparison is the most mga common talaga sa kanila to. So, dito, kung may cystic fibrosis ka, sabihin ka, oh, social mo naman, may lahi ka ba? Ganun. Kasi wala po ito sa ating mga Pinoy. Okay? More on the Western and Caucasians lang po. So, what is cystic fibrosis? Please, disclaimer lang din, read more on this also. Mas in-depth ha, kasi common ito. Lagi pong lumalabas si cystic fibrosis. Ayan, Mary. Okay, so your CF is a multisystemic disorder affecting the exocrine glands. So ano po yung may mga exocrine glands na part ng katawan natin, which is your respiratory, digestive, meron din po iyan. So etiology, may defect. Ano po yung defect doon? Yung cystic fibrosis transmembrane conductin regulator gene. So for short, CFTR gene po ang defective. So, ang nangyayari po doon sa mga exocrine glands natin, hindi po siya masyadong nakaka-absorb. So, matataba po siya. Sticky and matataba. So, pag nakita po natin siya sa endoscopy, tambok. They're thick. Okay, and then they produce sticky secretions. So, ang nangyayari, nagkakaroon ng mga GI symptoms. Okay, so tingnan po natin ito. So just the pathophysiology of your CF. So meron tayong defective na CFTR gene and then there is a trafficking. Nangyayari pong trafficking. So yun po yung nag-thicken na exocrine glands and then your exocrine glands cannot produce the proper glands that is your secretions. So ang nangyayari, na-alter yung mucociliary clearance natin. It's just producing more obstruction to it. Thicky and thick secretions, obstruction or hypersecretion of the mucus, nagkakaroon po ng pagbabara. Okay, so ano po ang confirmatory natin? It's the sweet test or your pilocarpine ionotophoresis. Ang tinatanong po dati dito yung sweet test. May isang NCLEX na nagsabi na anong confirmatory test. Okay, pero ang screening po natin is your IRD test. Kasi nga di pa po ang pancreas is the one responsible for producing more of your exocrines. So, ang nilagay ko na lang yung normal values. So, positive po siya sa IF if more than 60 millimoles per liter. Okay. So, management. So, pag sinabi po nating management, iba-iba din po kung ano po yung affected na system. So, digestive, respiratory, or reproductive. Kaya, pero nilagay ko na lang to sa respy kasi more common po siya sa respiratory. Okay. So, again, antibiotics, bronchodilators, and you do nursing interventions, chest physiotherapy. Pag digestive naman, yung may mga GI symptoms, diarrhea, vomiting, gano'n. Pancreatic enzymes, mga stool softeners, at enema. Okay? Kasi sa back constipation naman yung iba. Reproductive, may mga genetic counseling and CFTR modulators, but very rare. Okay? Sorry, wait lang. Sorry ha, wait lang.